Hey, it's Dr. Mitch. I just wanted to get all the medical cannabis stuff into one spot here. I don't think this is going to take too long. I want to emphasize a couple of key points. This is a big literature, it's constantly moving, but it's almost always underpowered, meaning the sample sizes aren't big enough to draw meaningful conclusions sometimes. Cannabis shows a lot of promise on a whole bunch of disorders. Nevertheless, it's not a panacea. It's not the cure for everything. And odds are high there might be alternative ways to get to symptom relief. So we want to keep everything in mind, add this to our arrows in our quiver, so to speak. But let's not overstate the case, because then we essentially draw a lot of criticism and get lulled into a false sense of security. So confounding politics and medicine, my biggest issue is that there seem to be different standards for different meds if they're at all psychoactive. So anxiolytics, right, the opiates, antihistamines, we know these have psychoactive effects, particularly early on in their use, and yet we seem to be completely willing to have that side effect be there, understand that folks are going to develop tolerance, and let them use them. I'm not clear why we don't grant cannabinoids that same luxury. And then everything I'm going to say here today is up to date in 2020, but literally next year things could change simply because this literature is so big and so few of the studies are appropriately powered. So right now, if you were going to do a randomized clinical trial on any disorder, right, literally anything that you think cannabis might work on, and you want an effect size of 0.3, maybe a third of a standard deviation apart, right? The cannabis group is going to do better than the placebo group that much. You'd need 175 to 180 people per group, right? And we're trying to draw conclusions from 20 people. We just can't do that. It's just not going to generalize across. And I'm talking about an effect size that is, probably bigger than the effect of antidepressants. And it's not a lot to ask, shall we say. Let's think about the costs and benefits of any treatment. Almost any treatment has main effects and side effects, so to speak. So we got to weigh and measure these. If a modest psychoactivity or elevation in mood is not a tragedy, and I'm not sure that it is, let's weigh that against the potential for symptom relief. Be mindful that there are idiographic reactions. Literally everybody responds to meds differently from even their identical twin sometimes. So we want to be sure we appreciate that there's going to be variance no matter what the main thrust is. Strain-dependent reactions. So we're really getting a feel for the different terpenes, and I was actually trying to look at them administered one at a time, but they obviously interact. What are the terpenes, these flavonoids, terpenoids, these molecules that contribute to flavor and aroma of cannabis, but also seem to be psychoactive on their own? So linalool, the one in all those lavender strains, is also in lavender and actually is relaxing on its own. So different strains are going to create different effects, and we really are, the research is in its infancy for that. For Marinol, we've got THC, essentially synthetic version suspended in sesame oil. It's psychoactive. It's basically an edible. It's fine. It's just that it's only THC, and so you don't have other cannabinoids to have that potential entourage, interactive, synergistic effect. And without any CBD in there, it can be super psychoactive, really a lot of magical ideation, discomfort, strange anxiety, and stuff like that. And it is definitely not a toy. You get one of those 10 milligrams and swallow it down on an empty stomach, you are going for a ride. If your tolerance is reasonable. And so it's not something to play with. I can't help but wonder why folks don't just use an edible instead, but we'll get into that. And then adjuncts and combos. Basically, let's not think of cannabis as a cure for anything so much as one of a series of treatments that are multifaceted and important. Almost every disorder has some behavioral contributor, something that's making symptoms worse, that can be addressed without any medication at all. So let's keep that in mind and definitely make those interventions because they rarely have negative side effects. Again, I want to emphasize drug safety. There are definitely safe ways to use cannabis medicinally, and I discussed them in basically the respiratory irritation lectures, but the bottom line is there's a way to use this without having negative consequences. So yes, Marinol, we got the 10 milligram, the 5 milligram, the 2.5. I'm really grateful to them for making the 2.5 because the 10 could be way too much and the 5 not enough, and it's just very hard to handle the dosage here. Obviously, you got to start low and go slow, and having the 2.5s gives you that opportunity. Randomized clinical trials say, okay, it's definitely great for weight loss related to appetite suppression, things along those lines. It's not perfect, and so for nausea and vomiting and things like that, you need something with a more rapid onset. Obviously, if I'm vomiting, I can't swallow a pill and hold it down, and there was a time at least when the 10 milligrams were $8 a piece. You don't want to throw up an $8 thing. So let's be mindful of the opportunities that having vaporized cannabis can provide. And I mentioned this GW Pharmaceuticals has that sublingual tincture, and now there are tinctures all over the West Coast, taking advantage of that entourage effect and the fact that a full plant extract probably is wiser than these single molecule approaches that we have. The plants didn't evolve by accident, so let's just be mindful of the idea that maybe there's more going on than what we know so far. It does ask for a little humility, but let's see how it works, and the data are really good for MS-related problems for this sublingual spray. Some compelling evidence on pain that I'll discuss. Well, and then first and foremost, there are a number of disorders that there really isn't a lot of evidence supporting, and I get into this in my book, but the bottom line is for Huntington's disease, for example, we're not seeing a lot of cannabis-based improvement. For Parkinson's, there was a time when the book came out that we didn't have any data on this. Now we have data suggesting at least 40% of folks with Parkinson's are using it and claiming it's helpful. It doesn't seem to be working in that same dopaminergic system. Maybe it's very downstream. It's enough to make you want to start a randomized clinical trial, but we've got more compelling evidence for a number of other disorders. And then there's definitely potential evidence for a host of other problems, but I want to be mindful of alternatives that are also really good. So yeah, cannabis does seem to help anxiety in a subset of folks who are anxious and think cannabis helps. I do wonder if the terpenes aren't the source of this. So if you've got lemon sour diesel and the limonene is in there, limonene, it turns out by itself can be simultaneously stimulating and anxiolytic. So wow, that sounds really cool. So by all means, huff a lemon, get yourself some aromatherapy, give that a try first. For social anxiety, we have splendid psychological treatments for social anxiety. That's really social skills training and exposure. You end up doing the very best when you're in the group treatment, which I find super fun. Everybody's in a circle, all socially anxious. Everybody's in the same boat, and you learn how to ask questions, make eye contact, listen well, and what a surprise. This stuff dies down to the point where you can go to a party and within 90 seconds, even without a beer, you're not anxious anymore. I do feel like we catastrophize anxiety a bit in our society. If you're not a little anxious all the time, I envy you. And truth be told, being a little anxious is not a tragedy. Let's not equate that with global thermonuclear war. The data on insomnia are intriguing. Definitely THC alters the way folks fall asleep and may improve their duration of sleep, but does also seem to suppress that REM stage, so it's not something you'd want to rely on too much. And the behavioral interventions for insomnia are actually very impressive. So if you're willing to go with good sleep hygiene, I know I'm perseverating on this a lot, but if you make your bed a cue for nothing but sleep and sex, right? If you turn off screens an hour before you hit the hay, those alone will be an astounding intervention. And then no caffeine after noon. Wow. It's stunning, but that alone could get you at least 15 more minutes of sleep every night and the opportunity for markedly more, and they're all free, right? The glaucoma data, yes, cannabis definitely decreases the pressure inside the eye, but not for very long. And we've got eye drops now that are cannabis based in other countries that are really superb for this. And you put them in twice a day and really control symptoms markedly better. There's some other ones that aren't even involving the cannabinoid system, works really well. This is higher in folks depending on if you're a crew that metabolizes salt differently, and unfortunately that often varies with ethnic lines. It's really a shame that we don't have better research on this, but truth be told, cannabis, you'd have to smoke it 4 times a day basically to really make this work consistently, and there's just an alternative approach. For PTSD, we've got randomized clinical trials now, but all the sample sizes are just really small. Jamie Bowles and I put out a paper essentially showing lots and lots of folks use cannabis for PTSD symptoms. Seems like the intrusions, that a thought jumps into your head that you don't want there, and some of the other hyperarousal stuff, folks seem to really think it helps for that. It's such a heterogeneous disorder that I'm not sure if saying, hey, this treats PTSD is a good idea, but certainly if you wake up in the middle of the night having had a nightmare and you've got some blue dream by the side of your bed, odds are high you're going to forget whatever it was that was disturbing you and get to fall back to sleep. I tip my hat to anybody who can make that work. I've had good luck with exposure-based treatments in PTSD. Some of my biggest success stories clinically are folks who've essentially improved from that. And I had a client who basically, didn't use cannabis during exposure, but used it at night to help him sleep, and things went fine. And then about 12 sessions out, he was just a whole new man. But can't argue from a single case. We need to have a big sample to really get a feel for what's going on. Mallory Laughlin and I did a paper where I had a really good idea where I just asked folks, how aroused are you now? And then had them fill out some of the PTSD combat scales and said, how aroused are you now, right? And just that change across time is an astounding correlate of PTSD, and folks who got more amped up out of filling that questionnaire were the ones who were using cannabis most and the ones who had some of the worst symptoms. So I kind of like it as an index, but I think that hyperarousal is really the target for cannabis. If it's enough to get folks to come to cognitive reprocessing therapy or just get them out of bed in the morning, by all means, let's do what we can with it. And then hypertension, yes, cannabis increases heart rate but lowers blood pressure. It's very strange. It does put folks at risk for passing out. You don't want to stand up too fast after a big bong hit. I can't recommend this as an intervention. I mean, the effects just aren't long enough. We've got meds for hypertension that have horrible side effects and sexual dysfunction, unfortunately. But the behavioral interventions on this are also good. If you can get on the bike, if you can stay away from cheese, if you can schedule your life so you're not so stressed out, that could be 10 points right there. Right? So by all means, let's take advantage of all the interventions we have. Potential evidence now for arthritis, dystonia, and seizure. So arthritis literally goes all the way back to Sheneng in 2737 BC, and by all means, he gets credit as the first dude for prescribing medical cannabis, but he's not even real. He's just the sort of Paul Bunyan of China, if you will. He's a myth. But clearly, treatment for arthritis with cannabis goes back millennia. Dystonia is just alteration in muscle function and flexion, really, and a lot of folks in individual case studies report some promise for it, but some of the MS patients say it helps, some say it doesn't. And then seizure is no longer in the potential evidence. We've got wonderful randomized clinical trials to show that cannabidiol rather than THC is the source of this, and God bless us for Oren Davinsky to bring this to our attention. He's got those kids who literally were seizing dozens of times a day, and then they get on a heavy dose of cannabidiol and end up not seizing at all, or just one a day, something like that. It's just categorically better. Such a blessing, man. I'm happy to say this is no longer in the potential evidence list. We have good data that cannabidiol can really help this. Obviously, the seizure disorders are really heterogeneous, so we don't want to make too much of any one finding, but folks who have seizures based on accidents and things like that, it's a really varied response. Now, likely effective appetite loss, I mean, I know that's a joke from the munchies in the movies and stuff, but this is stellar for folks who are struggling with any issues with keeping their weight on. And Christina Sharma and I've got a paper that should be out soon suggesting that a subset of folks, even with anorexia, are willing to rely on it and claim it's helpful, even though for some that makes them very conflicted. The seizure data I mentioned. Nausea and vomiting, again, this is an astounding, even in the animal literature, you see that drugs that tend to make animals really nauseated are, not as nauseating when folks get THC first. The spasticity, the muscle spasm, it's a strange mechanism, and I'm not sure if we've really got it worked out. I like some of the models, but yeah, definitely a low dose of THC seems to really decrease some of the muscle spasm, and this is just a key, again, to getting good sleep. As you can imagine, if you're not sleeping well, the irritation of these symptoms is even more dramatic, and man, it's astounding how big a difference that can make. Wheelchair-bound folks, spinal cord injury, they really swear by it. But again, we don't have a randomized clinical trial with over 150 people to show that's really the case. And then the placebo controls are hard now. I mean, everybody kind of knows what to expect from THC, so maybe we need to just do a low dose and a high dose and go with that. So for weight loss, and again, I don't mean to treat this lightly, and I know folks joke around about it, but if you've got AIDS or cancer, and you get down to a third of your regular weight, you're not coming back. Like, that is tough. And so anything you can do to combine this with Megace, some steroid, right? Anything will help you eat good food, right? Have a lean source of protein and something that's going to help you maintain muscle mass. By all means, let folks do this as much as they can. That is an inverted U. When you go way high, these 40 milligrams of THC in a day, folks lose their appetite. Obviously, that's going to be counterproductive, and there's definitely an expectancy effect in this. So in the Caribbean and things like that, people say smoke pot when you're hungry, so you won't be hungry, but obviously they're smoking way more than some of us. And the general pain literature, pain really is an inverted U. There's an optimal Goldilocks dose. If you get too much, it does actually make pain worse. And then the headache literature is astounding. Ethan Russo did a really stunning review on this, and particularly with migraine. If you've got the vaporizer handy, you notice the flashes or whatever it is that kind of lets you know that one is on the way. Run to the vaporizer. It doesn't have to be a big dose, and you got to head it off at the pass. Once you're already in the thick of it, it's probably just Imitrex and lying down, and that's it for your day. But what a chance to save your day for folks who have migraine. And then this Wallace paper's over a decade old now, but basically the take-home message is placebos just don't help pain at all, and too much THC doesn't really help either. There's a nice medium dose, and I think in this one it ended up being in that, they did 6 puffs, and it'd be around 10 milligrams for this crew, but it depends on the smoking topography and things like that too. But there's definitely too much on this, and so just be mindful of that if you want to use cannabis to help your pain. And then you can lower your opiate doses, and we've got self-report data. Philippe Lucas, wonderful guy up in Canada, and I have a paper on that where we do see folks get off the opiates thanks to cannabis. And then Woolsey, about 5 years after that, also essentially showed the same issue where you're going to get impressions of pain relief that improve somewhere in the mid-range of the doses, and obviously it's not going to last forever. If you do too much, it actually hurts worse, and you don't want that to, to be what happens. If you can start low and then just stay steady, you're going to be impressed. And what a surprise! I've got a number of folks in my inner circle who use this with a lot of success. Now, there's a lot of promise for some of these other ones, but we can't say, hey, this really does help. I just want you to be mindful of it, but don't assume this is a done deal. So the Alzheimer's and Alzheimer's management issues, and these are two separate issues really. Is this a cure for Alzheimer's? Gary Wenk has some amazing animal data suggesting that basically the neuroprotective effects of the cannabinoids could have a prevention of Alzheimer's effect, and I'm unfortunately, not going to be able to say anything about humans yet. We just don't know. It's not going to help late in the game, but it could help Alzheimer's patients eat better. And then there are some impressive YouTube videos of folks who are literally disappeared cognitively and then have some cannabis, and it's like they're back. And I wanted to weep, and I wish I'd had it with my mom. Alzheimer's management, well, so it at least makes folks easier to handle if they're in a good mood and not so combative and stuff, but also if they're eating better, they're going to sleep better, they're going to do well. It's really wonderful. For ALS, so we used to call it Lou Gehrig's. It's the one that Stephen Hawking had. That drooling is a frightening symptom just in that it tends to increase social isolation. And social isolation is the source of all evils, as we know right now. But the clincher is dry mouth that everybody complains about is actually a wonderful medical effect for them. And, anything that's going to help them eat and have a good mood too, well, that's a wonderful plus. It's not a cure, and I don't want to go that route, but for symptom management. For diabetes, again, this is kind of comical because anything that makes you so hungry, it seems like it's going to make you binge eat and wreck your diet for being a diabetic. But when you look at body mass index in cannabis users, it's not elevated. There are some strange impacts of at least THCV and some of the other cannabinoids and terpenes on blood sugar control. We just don't have the data, but it's not impossible. Dystonia I mentioned. Fibromyalgia, so diagnostically fibromyalgia is such a rough one. But generally, the pain and stiffness we've seen cannabis help with other disorders. Why not take this symptom approach and say, no, it's not a cure for fibromyalgia necessarily, but it certainly makes folks more functional, and that's always a big plus. Gastrointestinal stuff, particularly Crohn's disease, I feel like this is another one where the more I learn about it, the more I realize this is really heterogeneous, and trying to lump them all together may be ill-advised. But, I know folks who actually respond well to tobacco for these because it's vasoconstrictive. Other folks who just swear cannabis is going to help. And those CB2, those other cannabinoid receptors, are all through the GI tract. So it's not impossible. Let's at least get the randomized clinical trial and then see what happens. So glioma is basically something came out literally just today on this, but brain tumors and things like that, I know we've seen data go both ways, but generally there is a modest effect. The literature is not great, and I'll get into that more in a minute. The hepatitis and hepatitis management, hepatitis is a rough one, and everybody's on some liver transplant list, and man, livers you got to be kind to yours. That's all I can say. But obviously, THC is easier on your liver than alcohol, for example. So if that's going to help, by all means, let's go that route. But also, a lot of the meds for hepatitis are super nauseating, and so then people don't adhere to the protocol. If having the cannabis helps you take your meds, by all means, let's make sure we take advantage of that. Incontinence in both MS and spinal. So this is curious because this is not a mechanism that's very straightforward, and we don't know exactly how this works. We have seen with Benadryl and the opiates, some real problems with getting urination just started, and doesn't seem to have that negative effect, and yet it keeps folks from peeing in their pants, basically. And another one that can be so socially isolating and such a drag. And then for MS, again, I'm getting really disparate responses, but some folks who really seem to respond well, just that initial getting to bed, getting a good night of sleep, and then being able to get out of bed with a sativa. And I know I've got that paper that says don't wake and bake, but I think for medical users, if it's going to help you get through that first hour of the day, man, I can't point any fingers. So yeah, these are those new results that I just wanted to mention. Limited, moderate quality evidence that supports the use of cannabinoids basically as an adjunct to standard care for brain and central nervous system tumors. So, obviously it's not necessarily going to make your brain tumor shrink to the point where it's not there anymore, but this can be super helpful in a certain process, and looks like it helps people adhere to their medical programs for alternative treatments on this. It's, again, such a heterogeneous set of disorders, but definitely worthy of consideration. Now, we do have, it says there were very low quality evidence suggesting that cannabinoids were associated with adult onset gliomas. Yeah, there's a lot of covariates with that are hard to control for. This is a relatively rare disorder, so even having a random sample is kind of tough. Some folks who use cannabis are maybe 20% more likely to end up with a glioma than the average person. That really does need to replicate before we can know what to say of it. But yes, I'm willing to go out on a limb for saying it's effective for appetite loss, glaucoma, nausea and vomiting, pain, headaches, spasticity, and weight loss. Obviously, we don't need to do an ad for my books here. But yeah, if you need more information, my books are around. There are some great ones that have been out there. And I'm afraid, the biggest evil of all, here's my friend Bruce Merkin getting arrested. Like, each of the negative consequences associated with this just pales in comparison to jail time. And let's give folks a chance to treat their symptoms. It's literally every religion I've ever come across says, take care of the sick, right? Let's make sure we make good use of this. My book, Pot Politics, has 2 chapters that are sort of religion-based and have folks focus on the rationale, and what a surprise they come out very pro-medical. Thanks so much for tuning in, guys, and if you have any questions about medical cannabis, just put them in the comments here.